Brilliant. It's Eleanor Younger. I'm a consultant psychiatrist and I see patients from the age of 16 and upwards for Maudsley Private Care and Phoenix Mental Health Services. I don't need interest apart from that I find working with adults and teenagers very rewarding. Um, Treating people with ADHD make a difference to their lives. They're often very appreciative. However, on the other side, living with someone with ADHD can be very. I have a 14-year-old diagnosed with ADHD at the age of 7, and I have to support him in multiple roles, and he needs a lot more input than my younger son. I'm sure many of you are aware or have watched the Panorama Private ADHD Clinics Exposed. It was shown in May 2023. This is Rory Carson, who is an undercover reporter, and he had an ADHD assessment with the NHS, which was 2 to 3 hours, and they found him not to have ADHD. And then he went to 3 private clinics, a varying assessment, and was diagnosed with ADHD. And this highlighted the current issues of ADHD in the UK. What we don't know is that actually there were quite a few things that perhaps weren't correct with the Panorama show. It was the most complained around Panorama episode ever. And in the last decade, only 10 shows had over 100 complaints, and this had more than 1,500 complaints. And it's not the first time Panorama has had an episode which has been slightly controversial about ADHD. In 2007, they did an episode called What Next for Craig, which suggested that ADHD medication did not work in children in the longer term. And an investigation afterwards showed that it had failed to accurately report the findings of a 3-year follow-up study in the US of treatment with children with ADHD. It's done after the Panorama episode of over 2,000 people by the charity ADHD UK. 90% of people think that ADHD stigma has increased due to the show. And about 84% of people with ADHD think the show will stop people with symptoms seeking an ADHD assessment. But perhaps most importantly, this quote from Olivia Blake. Olivia Blake is a Labour MP and she was diagnosed with ADHD in 2021. And she said about the programme, this programme is incredibly harmful to those with the ADHD diagnosis. Given the massive shame many of us carry from not being diagnosed as children, the harm cannot be understated. We've spent our whole life thinking there was something morally wrong with us. And this is something that patients frequently tell me, the feeling that there is something wrong with them. So what are the facts? Well, NICE estimates the prevalence of ADHD in children is around 5%, and in adults in the UK, it's around 3 to 4%. And this is fairly consistent worldwide. The NHS Service Authority data showed that between April 2023 and March 2024, there was a 22% rise in adults receiving ADHD medication and about a 7% rise in children receiving ADHD medication. And almost 300,000 people in England were prescribed ADHD drugs. However, going back to ADHD UK's charity figures, they estimate that around 2 million people in the UK have undiagnosed ADHD. And actually only 58% of people with ADHD are in receipt of medication. So the reality is in the UK, that ADHD is actually underdiagnosed and undertreated. So why should we be treating ADHD? Well, medication for ADHD is effective. Stimulants have medium effect sizes of between 0.5 to 0.8, and non-stimulants have slightly lower effect sizes between 0.4 and 0.5. And when we compare that to the use of antidepressants in depression, the effect size for antidepressants is 0.3 to 0.5. And the use of antipsychotics in psychotic illnesses, the effect size is 0.2 to 0.6. And both these medications are readily prescribed. So the use of stimulants in ADHD is actually more effective than the use of antidepressants and antipsychotics. They also have a small number needed to treat. For lisdexamfetamine, the number needed to treat is 2. And for methylphenidate, you need to treat 3 people for 1 person to get a benefit. The medication for ADHD is also evidence-based. There's been lots of randomized control studies and meta-analysis that have shown that stimulants and non-stimulants are effective. Controlled studies have shown that ADHD medication is safe and effective in the longer term. And national registry studies have also shown that the effects of ADHD extend beyond the reduction of ADHD symptoms and have other effects as well. So ADHD may reduce life expectancy by as much as 11 to 13 years. Comorbidity is common and includes mental health conditions, neurodevelopmental conditions, substance misuse, and physical health. And treating ADHD has been shown to improve outcomes of comorbidities in mental health, substance abuse, and physical health. And there are a few caveats. So, for example, if you have bipolar and ADHD, you need to be on a mood stabilizer as well as an ADHD medication. If you have psychosis, the evidence is slightly less clear. And the thought about the improvement in physical health is that if you have treated ADHD, you're better able to look after yourself, to take your medication, and to attend appointments. But as the National Registry study showed, ADHD has effects beyond reduction of symptoms. So what are the consequences of untreated ADHD in adults? It can cause relationship problems, parenting difficulties, accidents. People with ADHD are less likely to enroll in further education or finish their education at the same time as their peers, have decreased performance and productivity, absenteeism, and increased workplace accidents. And again, treating ADHD has shown to have a positive effect size in the reduction in injuries, trauma, motor accidents, and criminality. Although the evidence is slightly conflicting in motor accidents and women with ADHD, some studies suggest there's an improvement, some studies suggest there's no benefits. So when should we consider ADHD? Well, this here is a picture of Heinrich Hoffmann, and he was a German psychiatrist born in 1809 who also wrote some short works, including poetry. And this is the story of Fidgety Philip. And I'll just read a little bit of it. But Fidgety Phil, he won't sit still. He wiggles and giggles, and then I declare, swings backwards and forwards and tilts up his chair. See the naughty restless child, growing still more rude and wild, till his chair falls over quite. Philip screams with all his might. And I think we're all pretty good at spotting the fidgety Philips, and they usually get picked up at primary school because of the externalizing behaviours. Interestingly, the last few lines talk about how Mama did fret and frown when she saw them tumbling down, and Papa made such a face in sad disgrace. And I think this reflects Olivia Blake's statement. People feel that there is fundamentally something wrong with them. Charlie, are you okay to share the video?
Yeah, just give me 1 second.
And this is another of Heinrich Hoffmann's poems.
Sorry, for some reason it's not letting me share sound.
Okay, I will share it. Hopefully you can hear it all right, but there are the words if you can't.
The story of me eating air. As he trudged along to school, it was always Johnny's rule to be looking at the sky and the clouds that floated by. But what just before him lay in his way, Johnny never thought about, so that everyone cried out, little Johnny there, little Johnny head in air. Running just in Johnny's way came a little dog one day. Johnny's eyes were still astray, up on high in the sky, and he never heard the cry, Johnny, mind, the dog is nigh. Bump, dump, down they fell with such a thump, dog and Johnny in a lump. Once with head as high as ever, Johnny walked beside the river. Johnny watched the swallows trying, which was cleverest at flying. Oh, what fun! Johnny watched the bright round sun, going in and coming out. This was all he thought about. So he strode on, only to the river's very brink, where the bank was high and steep, and the water very deep, and the fishes in a row. stared to see him coming so. One step more, oh, sad to tell, headlong in poor Johnny fell, and the fishes, in dismay, wagged their tails and swam away.
Be pleased that Johnny is rescued by two strong men. We are getting better at picking up the Johnny head in the air, the daydreamers, the inattentive people. But when else should we be ADHD? Sorry, I'm having problems going to the next slide.
The story of
The first case study is Ben, who's a 17-year-old boy in his second year at A levels. He had difficulty sleeping since when he was younger, and he found it hard to switch off. He did well at school, and in some subjects, teachers say he would do better if he listened. And I think this is really interesting because there is a difference in concentration and focus in people with ADHD. And if something is interesting, either they're interested in the subject or the teacher is good, it's much easier for them to focus. He did well in his GCSEs and first year of A levels, although his mum did need to sit down with him when he was revising to keep him on task. Again, people with ADHD, right, they can do very well at school. Many of them revise the night before their GCSEs, get top grades. But as they get further in education, it becomes harder and harder to do things last minute. He struggled with online learning during COVID, and he had problems motivating himself to work, and these problems persisted when schools went back. COVID, and particularly the lockdown, was a complete disaster for people with ADHD. A lot of people with undiagnosed ADHD have lots of habits that help them to manage. And suddenly, all of those things that they did stopped. They were unable to do jobs that they had done for many years. Ben's sleep got worse after COVID, especially on Sunday nights. He was assessed and diagnosed with ADHD, started on methylphenidate. He went on to get a first in a physics degree at a Red Brick University and started a master's in artificial intelligence. The second case study is Ava, who is a 19-year-old woman who presented just before she was about to start university. And she had always found life hard and a struggle. She struggled with friendships. She felt she was too loud, too much, too weird. She experienced panic attacks, anxiety, and depression throughout secondary school. And she had multiple talking therapies with the school counsellor and CAMS. And she said this helped, but didn't really resolve the situation. She did well in her GCSEs, getting all sevens, which for the old-fashioned amongst us, that's the equivalent of an A. But because she was at grammar school, most of her friends did better, so she felt stupid and described herself as the scum of the earth. She went on to do A levels during COVID and struggled with the lack of structure, the online learning, got further and further behind. She had a gap year to recover as she felt burnt out and tired after her A levels. And during this year, she was talking to a friend about ADHD, and it made sense to her. So she had an assessment and was diagnosed with ADHD, started taking methylphenidate 36 milligrams. And in her first year at university, she describes this as one of the best of her life. She got a scholarship because she was doing so well, and academically, most of her assessments were first. She had a good friendship group at university. And although she still struggles with her energy levels, anxiety, and emotions at times, these are happening less frequently. Rather than having daily difficulties, they happen monthly. The third case study is Susie, who is a 45-year-old single mum with a 14-year-old daughter, and she finds every day a challenge. She has problems with timekeeping. She always feels stressed and rushed, and she constantly felt overwhelmed by everything she had to do. And I think many of us who are parents and working probably recognise the picture on the left of trying to juggle multiple things. She had always had difficulty, but found it harder now she has more responsibilities. And again, this is quite a common presentation. When people don't have children during their 20s, if they have undiagnosed ADHD, they can compensate by working longer hours, working through the night when a deadline comes. But once you have more responsibilities, it's not possible to work those hours and do what you need to do to get through the day. She was also drinking over 7 coffees a day because she needed the energy. And when she went out, she'd drink alcohol excessively and use drugs when she went out because she just couldn't say no. And this is again a common presentation that people often with undiagnosed ADHD are using substances to self-medicate. She initially temped, but was working now in a permanent job. There had been some problems at work. She'd had disagreements with her line manager and been told she was too emotional for promotion. Her daughter has narcolepsy, and often what we see is that parents look into possible neurodiversity when their children are struggling at school, and they research ADHD and autism, and those symptoms resonate with them, and that's when they come and get an assessment. She started on methylphenidate XL 36 milligrams once daily, and she's still very busy, but life feels more manageable, and she also feels more confident in herself. The last case study is Rachel. She has a 7-year-old daughter and was recently separated from her husband. She had been with the community mental health team for many years and frequently saw the crisis team when her mental health deteriorated. She was diagnosed with emotionally unstable personality disorder in her 20s, and she also had diagnosis of anxiety, depression, affective disorder, and struggled with binge eating. Interesting enough, although when she felt high, she felt hyperactive, happy, and overexcited. When she felt low, she crashed, couldn't get off the sofa all day, but actually her mood was suppressed, her mood was okay. She felt anxious in social situations and often felt overwhelmed in social situations, and she doesn't like using the phone. And again, I would say this is fairly common with people with ADHD and ASD. They may seem very confident one-to-one, but they really hate making phone calls and using the phone. She had problems with opioids in the past, and like with the previous case study, she was self-medicating with coffee and Coke every day. There was also a history of neurodiversity in the family, and she had a brother with dyslexia and autism. When I first saw her, she was on high doses of Depakote, pregabalin, and duloxetine for her various mental health diagnoses. She initially tried atomoxetine, a history of substance misuse in the past, but didn't tolerate the side effects. And so she does on methylphenidate and was increased up to 54 milligrams once daily. She's managed to reduce the doses of mental health medication, and she no longer needs to see the community mental health team. She describes her mood as more stable, her brain feels nice and quiet, she feels more productive, feels better in herself, and she's also lost over a stone in weight due to stopping the binge eating. So when to consider ADHD? Well, we've talked about COVID and the effects of COVID on undiagnosed ADHD. Also, after transitions, people often present. As you get increasingly older, there's less scaffolding and support. Harder work may trigger off people getting an assessment. It's not, many people, as I said, are able to do work at the last minute, and that becomes harder as you move through GCSEs, A levels, and degrees. And when you have more responsibilities and there's more to juggle. If people have a history of depression, anxiety, and they're not responding to medication or responding in a different way, often if they've had multiple diagnoses, we should be thinking, is there something that we're missing? And eating disorders, people with ADHD have an impaired dopamine reward system. And so restricting and binge eating can be a way of getting instant gratification, that dopamine kick that people with ADHD need. When the DSM-5 came out, people discussed whether emotional instability should be included in the ADHD diagnostic criteria. And although it was decided not to, many people with ADHD have emotional instability. And this has led to misdiagnosis, especially in women, of emotionally unstable personality disorder and bipolar affective disorder. Many people with ADHD also have sleep problems. They have problems getting to sleep, and they may have a restless and light sleep. It's important to think about ADHD if people have excessive use of caffeine, nicotine, alcohol to try and manage their life. Substance dependence is very common in people with ADHD, or if they have an unusual response to substances. For example, if they find coffee makes them feel sleepy or relaxed. There's often a family history of neurodiversity, but this can be hard to pick up in older relatives and it's often undiagnosed. And as I've said previously, parents often seek help when children are struggling at school. Other times to consider ADHD are when people have chronically low self-esteem, if they complain that their mind is wandering or that their thoughts are always on the go, if they fail to reach their potential, or if life just generally feels hard. And to be honest, this list could probably go on and on and on. I'd now like to introduce you to Kerry Calvo. Kerry is an associate professor in health professions education at UCL and a retired GP. She has an interest in the method and practice of teaching and accessible learning, and specifically relating to neurodiversity. Her current doctoral research focuses on inclusive learning. So, Kerry, I'd like you to explain what were the reasons you decided to get an ADHD assessment?
Thanks, Eleanor. So, hello everyone, and thank you for having me at this session today. I think, listening to your case studies there, a lot of that from various case studies resonated, particularly things around drinking a lot of coffee. Fortunately, not the other substances, but I'm definitely an excessive coffee drinker. And I think for me, it was struggling with general practice was one of my big triggers, although at the time I didn't think about ADHD, but I found dealing with the uncertainty and getting really quite anxious was a challenge. And then during COVID, again the juggling of everything and just finding it with less structure of the routine of going to work and having my day planned out, it felt a lot harder to just keep a handle on everything and feeling like I was trying to multitask and not doing it very successfully. And then actually looking into neurodiversity diagnosis for one of my children has then prompted me to think about getting a diagnosis. In some respects, to try and reduce some of the sense of stigma around it, because I recognised a lot of what I was seeing in my child, in myself and in other family members. And I think there is still quite a lot of stigma. And so I thought, well, if I can get diagnosed and show, to see if I've got any kind of neurodivergence, then that may help with other family members and with my children if they're saying, well, actually, this isn't necessarily a disaster. So I think those were the things that prompted me to go and get diagnosed.
And I think also, Kerry, when we were talking, you mentioned about HRT and the effects on HRT and some things it not helping with.
Yeah, absolutely. So I've reached that delightful age where I've hit perimenopause, and I was getting a lot of perimenopausal symptoms and started on HRT. And HRT really helped with the night sweats and the hot flushes and the dry skin and all of that kind of thing. But it didn't help with the brain fog, and it didn't help with sort of irritability. So feeling just more emotional than I had done previously. I have always been somebody who was referred to as a child as highly strung. So probably emotionally unstable. I cry very easily, and I can get grumpy very quickly, and then it burns out very quickly, and I'm fine again after that. So I'm quite surprised that I've never been labelled as emotionally unstable per se. But yeah, certainly that kind of I found it harder to mask that when I hit perimenopause.
And Kerry, you made the decision not to go on take medication, and I was just wondering, what difference has the diagnosis made to your life and different areas of your life?
Yeah, I think it's really interesting to think, is there any point in having a diagnosis if I don't take medication? And it's something that I have considered and I haven't ruled it out. I think for me, I've now identified so many coping strategies that at the moment it feels like everything is okay, and that maybe it's not the right time for me to start trying medication, because obviously everything does come with the potential of side effects. And so, there's been a little bit of reticence. The other reason, to be honest, that I'm slightly hesitant to take medication is that I know there's problems with accessing it at the moment. And I know lots of people have had difficulties getting hold of medication. So in some respects, I'd rather sort of stay off it and not be chasing to try and get hold of medication that I then find is particularly useful. But I think for me, it's sort of leaning into some of those ADHD symptoms and actually using them to my advantage. So I'm somebody who can hyperfocus. If I'm doing something like working on a set of slides for a presentation, if I'm working on a video that I'm editing, anything like that, then I will really hyperfocus on it and get the job done. I tend to be somebody who will get jobs done relatively efficiently for people because I do them there and then, because otherwise it goes out of my mind. So if someone asks me to do something, I do it. I work with a lot of lists, to-do lists, and visual reminders. So if I want to make sure that I remember to take, for example, my iPad on the train to work, I will leave it somewhere that I'm going to virtually fall over it in the morning so that I remember to pick it up and take it. I used to have a lot of post-it notes around my room at university reminding me to do various things. Elle's laughing now because we were roommates at uni. So having things about revision notes and prompts, and so very much visual reminders. And I think so leaning into some of that. But I think also it's slightly complicated for me because I've got although it's the autism diagnosis is slightly informal at the moment. The psychiatrist that I saw has agreed that she thinks that I have autism ADHD, and so I think some of that has a bit of a balance, and I'm slightly wary of what effects the medication have at unmasking some of the more autistic tendencies.
And you also mentioned about feeling more confident in yourself, knowing that there was a reason for some of these difficulties.
Yeah, absolutely, because I think it sort of legitimizes some of it. So there's a reason, and other people are also like that, and it's not just me being weird. I never realized, for example, that there are a whole load of people out there who, if someone mentions a phrase, it will trigger a song for us. And I've subsequently discovered that's a very ADHD sort of tendency. So I will sort of, immediately I get a song filling my head if someone's mentioned a certain phrase. My head is very noisy. There's always something on in the background in my head. It's like I've got a radio station playing. And just finding out about some of those things has helped me with techniques like getting off to sleep better, because I now play meditative sleep music in my room at night. And that allows, because I can actually hear that externally, it sort of quietens down the internal noise and I can get off to sleep better.
Do you think it's had any impact on your work, knowing having a diagnosis of ADHD?
It's given me a very big focus of interest. So actually, it's been fantastic. I'm doing my doctorate, as you mentioned, and I've been looking into. I'm really interested in curriculum design and pedagogy, and actually looking now at inclusive pedagogy, specifically around neurodivergence and neurodiversity. That's really given me something to focus on. And it's also helped, being very open about my diagnosis, I think has also helped to serve as a role model for some of my learners. So I've had quite a few learners who've now come up to me and said, well, actually, I didn't want to disclose my neurodivergence, but you're very open about yours. And so it's led on to some really good conversations. And I've worked with some of them to help design our learning. We do a lot of online learning, so thinking about how we can make that more accessible and inclusive.
And Kerry, as a GP and a patient, what do you think you would like GPs to know or understand about ADHD? What one thing?
I think that it can affect older people as well, that it's not just your fidgety Phil and your sort of Johnny head in the air. It's not just the child who climbs out the classroom window or is away with the fairies. Actually, a lot of women, I think in particular, have masked for a long time unknowingly, and I think it's not just a fad. It's not a fashionable diagnosis, and I don't think people should be scared of suggesting the diagnosis.
Okay, brilliant. Thank you very much, Kerry. And Kerry is going to be around at the end if you have any questions for her.
Yeah, feel free to post them in the chat to me.
So what can we do to support people while they're waiting for an ADHD assessment? And I'm sure many of you know that the wait for ADHD assessments, particularly in adults, can be very, very long in this country. And ADHD UK, the charity, did a Freedom of Information Act in October 2023 and found that the waiting time for ADHD assessments in adults varied from 12 weeks in Dorset, not quite sure how they managed to get it so low, to over 550 weeks or almost 10 years in Herefordshire and Worcestershire. They also found that there's almost 20,000 adults waiting for an assessment, but actually only 21% of healthcare boards knew what their waiting numbers were. And so it's likely that the numbers are going to be much higher than 20,000. So what can we do? Well, I think, as Kerry said, even the discussion of ADHD as a possibility can be helpful. And it can be a huge sense of relief to people that they are not fundamentally flawed as a person. And the book, You Mean I'm Not Lazy, Stupid or Crazy, is a really good book to highlight this. And lots of people generally believe that they are lazy, stupid, or there is something wrong with them. I also really like the website Attitude. Attitude is an American website, but it talks about strategies for managing ADHD at work, at home, and in relationship, and has a lot of free webinars. And then the little picture in the corner is the ADHD alien. And this is an Instagram account, and it's comics by a woman with ADHD, and it's her experience of ADHD. And it's a really good visual representation of ADHD and its challenges, and can be quite a good way of checking in with your own symptoms and seeing what difficulties you have. Next slide, please. So exercise has been shown to have a positive impact on ADHD functional outcomes, and it may enhance motivation, increase energy levels, and reduce feelings of depression and fatigue. It can also, it's been shown to have a small improvement in concentration and executive functioning. Sleep is very tricky for people with ADHD. People with ADHD are often more alert in the evening because there is a delay in the melatonin pathway, and so they become sleepy later on in the day. They find it difficult to switch off their thoughts, and they're often, if they've left doing things to the last minute, there are less distractions in the evening to get things done. And finally, getting to bed is dull and boring, and so you're going to put it off if it's not something that interests you. Interestingly, sleep often improves on stimulants, despite stimulants causing problems with sleep. And this is usually thought to be because their brain is able to switch off and switch down. It's important to treat any comorbidities that might be contributing towards sleep problems. And giving sleep hygiene advice, and often repeatedly, is really important. People with ADHD often have poor working memories, and so you may need to repeat things several times. CBTI, so cognitive behavioural therapy for insomnia, has been shown to be effective in problems managing sleep. And the computerized version is shown to be as effective as seeing a psychologist. And Sleepful is a free app that people can use to do a CBTI course. And finally, melatonin can be really helpful. As I said, the melatonin rise is often delayed, which causes the delay in the sleep-wake cycle. And so you can use melatonin, which is helpful and is also safe. Next slide, please. It may be possible to get cognitive behavioural therapy for ADHD through IAPT, and targets in particular work on procrastination, prioritisation, distraction control, organisation, and planning. And the Adult ADHD Toolkit is a self-help CBT toolkit. And I wouldn't suggest people with ADHD read it from cover to cover, but instead to look at bits of the book that are most relevant to them and try out the different strategies. Mindfulness has been shown to be useful to help with inattention, but it can be hard for people with ADHD. The breathing space is a short mindfulness exercise that lasts a couple of minutes. People often find mindful movement or yoga and Pilates more helpful than just sitting and trying to focus on your breathing. And informal mindfulness can be helpful. So try to be in the moment when you're having a shower or when you're doing the washing up. And the Oxford Mindfulness Centre has lots of free meditations and also lots of courses that people can do. Next slide, please. Other things that can do is, if you have the right job and adjustments are made, people with ADHD struggle less. Hot desking has been a complete disaster for people with ADHD. You can advise patients to apply to access to work. You don't need a diagnosis to get access to work. And this can look into what reasonable adjustments need to be made, and also can fund ADHD coaching, even if you're waiting for the diagnosis. If you're a student, it's worth applying for Disabled Students Allowance, and adjustments can include specialist software, proofreading assignment, and academic coaching or mentoring, which is very useful in the third year when people are doing dissertations, because it's a long-term goal with no deadlines. Next slide, please. And then there are other things that can be helpful. So often people with ADHD work better to deadlines. Having the right amount of background noise can be helpful. And this can vary both with individuals, but also with what they're doing. So sometimes you need to have the TV, radio shows on in the background. Other times you might find loop headphones, which reduce the background noise, helpful. Being able to move and having something to fidget with and have a standing sitting desk is also really important. People with ADHD often have sensory processing difficulties and they need to move more to stay alert. And these things can help with that. And as Kerry mentioned, visual reminders and alarms are really helpful. Body doubling can be useful to get jobs done. And this is where someone sits with you to make sure you stay on task. And there's an app called FocusMate, which does this. You meet someone online, you arrange an appointment, you hopefully get your task done. People with ADHD have a real difficulty estimating time, and they often describe having time blindness. So setting your clock slightly fast and assuming that tasks will take 50% longer. And trying to get, as we said, the right type of work, so novel work, a work that has variety, outdoors work, practical work, can all be easier for people with ADHD. And then the other thing that you can do is try and work out where you can hyper-focus. And there's a helpful mnemonic to remember, which is sirens. So is something stimulating, interesting, rewarding, is an exciting or an emergency, novel or new, and has the right amount of stress. Next slide, please. So in the UK, in adults, we have 2 stimulants that we use for ADHD and 1 non-stimulant. And the first stimulant is methylphenidate, and this is also known, different formulations include Concerta, Equazim, Medicanet, and Ritalin. It's easily absorbed. You notice clinical effects within about an hour. There's no specific interactions with the P450 enzymes. And although it's excreted by the kidney, it's not a major problem in renal insufficiency. It blocks the reuptake of dopamine and noradrenaline in the prefrontal cortex and the subcortical striatum. And the dose range is between 5 and 100. And I usually find that teenagers are on about 36 milligrams if they're on the methylphenidate XL, and adults usually need about 54 milligrams. Next slide, please. The second stimulant family is the lisdexamfetamine, is the amphetamines family. And in this country, we have the lisdexamfetamine or Elvance, which is the long-acting stimulant, and dexamphetamine or Amphexxa, which is the short-acting stimulant. Again, it's easily absorbed and rapidly distributed, but it has a slightly slower clinical effect than the methylphenidate. It is metabolized in the liver and it's excreted by the kidney, and you do need to be careful in kidney insufficiency. It works in the same way as methylphenidate, but the dexamphetamine also acts as a releasing agent of dopamine. Out of all the stimulants, dexamphetamine is the most expensive and has the most potential for abuse, so we tend to use it after we've gone through all the other stimulants. The usual daily dose for dexamphetamine is about 50 to 70 milligrams. And for dexamphetamine, it's a much more variable. I have some patients who only need a tiny dose of sort of 7.5 milligrams a day, and other people who need 20 milligrams 3 times a day. Next slide. Then our non-stimulant is atomoxetine, also known as Strattera. And this is a selective noradrenaline reuptake inhibitor, and it's a much more conventional medication. So it can take a couple of weeks for people to notice an effect, and it can take a couple of months before people have an optimal effect. It works in the prefrontal cortex. You need to avoid stopping it suddenly and ideally reduce it over 2 weeks, otherwise you get the withdrawal symptoms that you might get on antidepressants. It's metabolized by the liver, so you have to be careful in liver impairment. And a significant minority of the population are poor metabolizers, so they often have more side effects, but possibly greater benefits on their ADHD. Now, in the BNF, the advice is to start at 40 and increase to 80, but I have never met anyone who's able to tolerate the side effects of atomoxetine when they go in at such a high dose. So I generally recommend starting at 18 milligrams and increasing gradually upwards through the steps until you get to a therapeutic dose. It's useful because it provides continuous cover. So if people struggle in the evenings, or if they're ongoing substance use as well, and you don't want to use the stimulants. Next slide, please. So what to consider when starting medication? So generally, we use lisdexamfetamine or methylphenidate first line, and you should titrate the dose up until you get optimum symptom control with minimum side effects. Now, about 50% of people do well on either stimulant, but about 15 to 25% of people do better on one than the other. And so after 6 weeks on an adequate dose, if there's not a sufficient benefit or people are getting side effects, then switch to the other stimulant. Lisdexamfetamine is our longer lasting stimulant. It lasts up to 13 hours. So if people are responding to lisdexamfetamine, but the effects are lasting too long, consider switching to dexamphetamine. Consider atomoxetine if people have a poor response to stimulants or they become tolerant to stimulants. I generally recommend prescribing generic medication because it's cheaper and there's less problems if there are shortages. Many people may need a top-up of the immediate release stimulants in the late afternoon if they've taken the long-acting stimulant in the morning. Some people may need higher than recommended doses. And if people aren't responding to medication or they've got a partial response, there may be comorbidities, and this is often ASD. Next slide, please. So before starting medication, you need to check for any mental health comorbidities. And generally, you can start medication despite of the comorbidities. You have to be careful in unstable bipolar, and people should be on a mood stabilizer if they're starting ADHD medication, and also cautious in psychosis. Consider whether there's a history of substance misuse and diversion, although often this doesn't stop you prescribing because many people are self-medicating with substances, and actually starting them on ADHD medication reduces that. Look for any medical history and contraindications, and these include glaucoma, hypothyroidism, and cardiovascular disorders. What current medication they're on. You need to check their weight, pulse, and blood pressure. And then there are certain times when you need to do an ECG or a cardiovascular assessment if they have a past medical history of heart problems or a family history of early cardiac disease or sudden death in a first-degree relative, or if they're on medications that prolong the QTC interval. Next slide, please. Once they're actually on the medication, the monitoring is quite simple. So they should have their heart rate and blood pressure checked every 6 months, and their weight should be measured every 6 months. And they should have at least an annual review with an ADHD specialist. We no longer recommend drug holidays as essential, although many children and students do stop their medication during the holidays. But what we should be doing is reviewing the dose of medication and document the need to continue on it. And ADHD medication is important to review if there's a change in life. For example, if they change their jobs, if they change how much exercise they do, or a change of responsibilities, they may well need a change of dose. Next slide, please. Now, I'm sure many of you have had problems with stock issues. So currently at the moment, the shortage in the UK is of methylphenidate XL or Concerta XL tablets. Generally, what I would recommend is prescribing generic methylphenidate XL tablets because this gives you options of lots of different formulations, including Zenodate, Zagotin, Dalmazart, Concerta, and Mataride. I get my patients to check what doses pharmacies have. If they're on 4 milligrams, this can be made up of an 18 and a 36, 2 27s, or a 54 milligram tablet. And so if patients check first and then let their GPs know, then at least they can get the right medication for which the pharmacy has available. If you're really struggling, then I would recommend prescribing methylphenidate immediate release tablets. And it's important to note that 18 milligrams of the long-acting is equivalent to 15 milligrams of the short-acting. So if people are on a dose of 54 milligrams a day of the long-acting, this is about 15 milligrams 3 times a day of the immediate release. There are other long-acting methylphenidates, so there's Equizim XL and Medicanet, and these are modified release capsules, but they actually have a slightly different release profile. So Concerta is 22% immediate release and 78% modified release. Equisym is 30 and 70, and Medicanet is 50 and 50. So they do have a different feel. And so generally, I recommend prescribing the immediate release rather than prescribing these. They also only last up to 8 hours, so may need to be prescribed twice a day in adults. Next slide, please. So depression often coexists with adult ADHD, and the prevalence is thought to be between about 20 and 50%. And although all antidepressants may potentially increase the risk of serotonin syndrome if you're also on lisdexamfetamine, and fluoxetine and paroxetine may increase exposure to amphetamines and atomoxetine. Also, you need to consider the blood pressure when combining stimulants with SNRIs. Ultimately, combining SSRIs and stimulants is not associated with an increased risk of adverse events and is commonly done. Next slide, please. I suppose the other thing to note about medication is we have only routinely been prescribing adults with ADHD medication in the last 10 years. So a lot of time we are using medication off-label. And these are some of the other options that people may take. Guanfacine, which is used in children in the UK, increases noradrenaline signal. And this can help with sleep, and it can be useful if you have tics, a history of anxiety or hypertension. Bupropion is widely used as an antidepressant in the US and Southern Europe, and it's often a good antidepressant in ADHD if people haven't responded to SSRIs or have had excessive side effects. It's a mild stimulant, so it can have benefits and actually treat ADHD. So if you have someone who wants to give up smoking and you suspect they have ADHD, bupropion might be a helpful medication for them. Potentially, venlafaxine and mirtazapine may offer additional benefit in ADHD because they also have a noradrenergic effect. And as we talked about, melatonin can be really helpful with people with ADHD because of their delayed onset of melatonin release. Circadian is the most commonly available melatonin in this country, and it's a long-acting medication. It's important that people take it 90 minutes before bedtime so it has time to get into the cycle. And if it's problems with falling asleep, patients can crush or chew it. Next slide, please. And finally, this could actually be a whole seminar in itself. So this is some very quick and key points. Women often have an internalized presentation, and so they can be overlooked or misdiagnosed. They often have more inattentive symptoms, and they often describe feelings of overwhelm and racing thoughts. They tend to have more emotional regulation, and women are very good at compensating, better so than men, but this often comes at a cost of fatigue and burnout. We're starting to understand more about how hormones affect ADHD, and we think this is due to the fact that estrogen potentiates the actions of dopamine. So many people with ADHD describe more severe PMS and PMDD. Medication may be less effective in the second half of the menstrual cycle prior to their period starting. And ADHD symptoms may improve during pregnancy, but also worsen during the perimenopause. Next slide, please. So thank you very much for listening. I don't think we've left very long for questions, so apologies for that, but we've got about 5-10 minutes now for questions from either myself or Kerry.
Yeah, I can take questions for about 2 minutes and then I've got to go and teach somewhere else. I'm afraid, typical ADHD overcommitment. But I have answered a couple in the text, in the chat.
So Paul, you put your hands up. Paul Cronin.
My name's Paul Cronin. I'm a GP. I was actually diagnosed with dyslexia last year at 52 years of age. So I understand the sort of need to sort of sometimes have an answer for why you struggled. And I'd love to be able to work in ADHD. And is there any suggestion about how GPs can work and maybe have an extended role in ADHD? Do you think?
Yeah, so UCAN, which is sort of the adult ADHD gurus in this country, say that anyone can diagnose ADHD as long as they have enough experience in mental health to know what other conditions may be causing it. And they also recommend, if people are prescribing, that they're in a peer group, to have supervision about their prescribing of medication. So I would recommend doing the UCAN course, the assessment and diagnosis course, and potentially the treatment course. And I think probably if you've worked in general health for quite a long time, GP for quite a long time, you would probably feel that you had sufficient confidence to do that.
Excellent. And I believe you, Maudsley does a course as well. Is that right?
Charlie may be able to comment more on that. I think they do, but I'm not fully up to date with that.
Brilliant. Thank you very much for the help. So that's UCAN, is it?
Yeah, they are quite booked up, the courses. They run several during the year, both online and face to face.
Brilliant. Thank you very much. Thank you.
Joe, you've got your hand up.
I'm retired now as a GP for what I've been qualified for 47 years, and I retired a year ago. Given that the symptoms of ADHD are quite wide, you say depression, there's alcohol, there's eating disorders, employment problems. In general practice, aren't most patients already under the care of a general psychiatrist? And how long does it take them to twig that this patient may have ADHD and refer them to you? I can't see many referrals being referred directly to an ADHD clinic saying, I think this patient's got ADHD. Or am I wrong?
I think usually actually it's the patient that refers. And I think, there are disadvantages to social media, but there are also advantages to social media in that people are much more aware of ADHD. We would probably argue, and I mean, I am a general adult psychiatrist. I enjoy ADHD and I do a lot of work in ADHD. But I think most psychiatrists feel that ADHD should be managed by general psychiatrists because it's important to rule out comorbidities and other conditions. I think the difficulty is currently there are no real ADHD services readily available across the country. So actually, the pathway for referral is really difficult and varies depending on where you're based. I think we have only really been starting to think about ADHD in adults in the last 10 to 15 years. Certainly when I did my training, I was taught that ADHD magically stopped at the age of 18 and that you couldn't have autism and ADHD together. So I think over the last 5 to 10 years, it's been a real learning curve for psychiatrists as to what is ADHD and how it presents, and seeing a lot more of the inattentive side of ADHD and the emotional regulation side of ADHD. So I think we are still learning and we are still catching up on how it impacts adults.
Yes, I think a patient would come to us and say, I think I've got ADHD. Obviously, we take the history in the 10 minutes GPs have got.
Mm-hmm.
He would almost refer. I'd be very surprised. Yes, and Kerry's waving. I'd be very surprised if we would just try and manage it ourselves. The other thing, of course, I mean, diagnose it ourselves, of course. Sorry, I mean, to try and, we're not experienced in this perhaps, and we would refer on. But the other trouble that we have in general practice is that we get a letter saying, will you please prescribe one of the amphetamines, please do an ECG, please weigh, check the blood pressure, and do this, this, and this. Can't that all be done in secondary care? Do you all do ECGs? Do you all do the bloods? Do you weigh the patient, check the blood pressure? Have a hotline that they can contact you should there be any problems? Or do they come? I'm flying the flag for the GP. My GP colleagues in the audience, might be applauding me and you would talk about me when you go home. But is there any way that it can come more to secondary care, to you, to psychiatrists, than coming to GPs?
I think the problem is often no. Often community mental health teams are in small buildings in little villages with very limited physical health facilities or abilities to check. We used to have clozapine clinics that did a lot of these things. Many of those clozapine clinics have been stopped due to funding issues. Generally, I don't expect GPs to do blood pressure, pulse, weight and height. I'm happy for patients to do that. And during COVID, that was done quite successfully. ECGs are a little bit more tricky, but reality is we don't need to do ECGs on very many people. And so physically, most things can be done before starting medication by the psychiatrist.
Thank you.
So we are slightly over time now, Eleanor. But I just noticed that Lily has put her hand up in the chat. Is that a question that you'll be happy to answer now, or would you
Yep.
rather conclude the session? Yep. Okay.
Oh, hello there. Hi. I was trying to work out how to turn on my mic. So, yeah, thank you so much for the talk. I mean, it's been very informative. There's so many really useful sort of tips and things that you've mentioned, and especially going through the different medications as well is really helpful. I just wanted to sort of pick up. I mean, I think for things like one of the I think the main challenge I feel in primary care is that we get a lot. I mean, in my practice, I work in North Southwark. We get a lot of patients actually coming to us saying, "Oh, I think I might have ADHD." As you said, there's much more awareness. Often people do notice when their children are having difficulties, but just generally, I think within society is much more awareness. But it's just, I think the challenge really is that there's no commission service for adults with ADHD. In Southwark, there's a
Yep.
lot of regional variability, even within SEL. I mean, obviously, we're South East London. We're meant to be um one big patch, but there's big commissioning differences even within SEL, and obviously nationwide as you outlined earlier. But within Southwark, we pretty much can only refer them adults to the right to choose providers. So we tend to refer them to Psych UK, but even they, yeah, as you know, there's like a year and a half wait.
Yep.
So it's I think there has to be some kind of addressing of the commissioning gap
Yep.
because otherwise, what can you do for the patients? Those tips that you've given of, helping them while they're waiting is really, really useful. But fundamentally, that doesn't change the fact that they're sort of sitting there. And as you said, often adults are people who have been coping and struggling and having all these sort of impacts from undiagnosed ADHD, for much of their lives. And that is a real challenge. I did also just want to mention, just in response to the previous attendee's question about monitoring. So, we do have clear shared care guidance, which does outline what primary care should do, what secondary care should do, and it does say basically who does the weight and the height and the heart rate and things like that. But just I think one other challenge is that the yearly reviews that these patients are meant to get, I'll be honest, they don't often seem to get them.
Yep.
So again, that's another challenge because we have these shared care guidance, but actually we do, I think it's just services. They don't, there isn't the capacity for all these additional, hundreds of patients who need suddenly yearly reviews, and I know that psychiatry services are stretched like every other service is.
Yeah. Oh, I completely agree. I think we need to rethink how we do ADHD in this country. Um, our services are not fit for purpose, and patients who live in one postcode shouldn't get a better service than patients who live in another postcode. I think that's why a lot of patients choose to go privately to get the assessment. And actually, I think from a GP perspective, even just raising it as an issue with patients can be really helpful. Not everyone chooses to go on medication, and often the low self-esteem, problems coping, difficulties, if you know that there's possibly a reason for it and you can look up strategies, that can be really helpful. Again, with the annual reviews, I completely agree. It's really hard. And I would say annual reviews are generally more like 18-month reviews, if at all, and increasingly being stopped. And I think this is something that we need to review. I hope that by giving more information about medication, it would give people confidence in what changes they could make within the guidance. So, if someone is on methylphenidate XL and it's not available, what are the other options? So they don't constantly need to be sending people back to psychiatrists or waiting for that. But I very much hope in the next 5 to 10 years we have a proper system that is funded for people with ADHD, because actually treating it makes such a difference to adults, which is why I'm speaking about it and why I feel very passionate about it.
Thank you, Eleanor. And could I just squeeze in one quick question? Although I completely understand if you're like, actually that's too much to answer. What is the main difference between amphetamines and dexamphetamine and things? Because I've had patients saying, "Well, should I just go and take some drugs then?" I mean, I think they're being slightly flippant when they say that, but that would just, yeah, I don't know if that's probably not a quick answer.
Um, so yes, I would say lots of people, and sometimes quite surprisingly, people have self-medicated. You don't sort of think about 40, 50-year-old women going and getting MDMA, which they then take. Um, it is different. It obviously we know what we're prescribing. It's a bit like prescribed cannabis. We know what's in it. Whereas obviously if you're taking MDMA, it's less controlled. But caffeine can be really effective for ADHD. Nicotine can be really effective for ADHD. It probably doesn't work as well. And actually, there is a benefit from taking the medication. And ultimately, it's cheaper than illegal drugs, and you're less likely to get into trouble.
Thank you.
Any other questions? I have put my email address. I'm very happy for people to email me if they have any questions about the presentation or any questions about patients in particular as well. And we haven't managed to address that today. Harvey, you've got your hand up.
Oh, can you hear me now?
I
Is that
can,
better?
you.
Hi, thank you so much for your time today. I thought it was a really interesting talk. Unfortunately, I got my Zoom kicked me off the meeting halfway through for 5 or 10 minutes, but never mind. I had a question about whether you're aware of any links that exist between services that support people with substance misuse, like Turning Point, for example, and ADHD services, or whether you sort of think that's a sort of, potentially helpful thing
I
to
think
have.
I think it would be a helpful link. I think about 10 years ago, so substance misuse sort of and psychiatry services were separated, often run by different trusts and more recently done by different charities. And so there is less sort of interaction between mental health services and substance misuse. And I think patients and professionals lose out on it. So not aware of any links. I should imagine a lot of it is personal experience from professionals that probably bring it up and have the links rather than any specific links.
Thank you very much.
Okay, so on that note, I think that's us pretty much done for time. I just want to say thank you again to everyone that joined us, and of course, thank you to Eleanor and Kerry for sharing their experiences. Just to reiterate as well, we were recording, or we are recording, the session. I'll have the video edited and handed over to our marketing team to then put on our social media channels. I'm just going to relink those in the chat. And Eleanor, any kind of closing thoughts or feelings just before we conclude?
No, thank you very much for attending. I would be happy if it would be useful to come and do a presentation about ADHD in women. And I'm also very happy for people to contact me, and I put my email address in the chat.